Next, we're going to have Professor Tawesak Tanwandee. I think there's no need for much introductions about Professor Tawesak. For briefly, Professor Tawesak is an international leader in hepatology, and also he is president-elect of the Gastroenterology Association of Thailand. Professor Tawesak, the stage is yours.
Good morning. Thank you, the organizing committee, for the invitation, especially Professor Mahachai and Professor Vilaichun for this prestigious symposium of the ASEAN Gastro 2025. So I got the hard work for highlighting to you the recent highlights and year in review in hepatology. So here's my disclosure. So I think when you look at the publication of the past several months of this year and also the last quarter of last year, so most of the publication, I think I will dedicate it for this highlight to the focusing on muscle disease and MASH for the complete circle, so from definition, identification, and the treatment. And this year marked the first year when we have the treatment for MASH. So we all know that muscle disease affected at least 1/3 of the world population. So that includes in ASEAN country, as you can see in our in our region here, you can see that the population all around the world, majority going to be now affected with metabolic fatty liver disease, and is still increasing. And the term just recently renamed from NAFLD a few years ago to it is the Asia Pacific who is the initiative to changing the exclusive term. You need to exclude everything to inclusive term. So we named it MAFLD, so metabolic associated fatty liver disease, and the guidelines had been initiated in 2020. By the way, the Western society, they got us, the Delphi is a consensus that fatty is kind of bullying term. So they changed from fatty to steatotic. So the name MASLD now will change. And all of publications submitted for published in the Western journal need to be named MASLD, not MAFLD. So that is the way that they change the name. And then but we try to have the survey across the local languages in the whole world. The local language for fatty liver disease remain fat, not steatotic. And with that, this year we launched the second editions of the guideline for the identification and the treatments of fatty liver disease, and we retain the name of MAFLD in Asian society. So this is a disease that is more systemic than we originally thought. So it's not just affect the liver. So it can be outside of the liver. That increased the risk of type 2 diabetes for those without diabetes at the beginning, at least 2 times more than a non-fatty liver. And also many cardiometabolic complications, at least 1.5 times more than normal, and increased cirrhosis from 2 to 10 times more than non-fatty liver. And the diabetes and fatty liver disease shows many similar pathological pathways. So that's why this kind of derangement of metabolic pathway can share similar metabolic complication. As you can see, from fatty into steatohepatitis, and from steatohepatitis, from fatty to steatohepatitis and to cirrhosis. So the percentage of becoming more progressive from 1 to 10% every year. And you can see on the right that, the more aging, so it's kind of aging process. So you see from F1, it takes almost 30 years, but from F1 to F2 is shortened to 70 years, but F2 to F3 is just about 5 years. So it kind of accelerate over the when you become more older. And also the liver-related mortality, you see that it's going to be linear before F3, but after F3, the acceleration is going to be very high. So if you need to capture MASH or steatotic hepatitis, you need to capture it fast and then intervene before the patient becomes cirrhotic. Now, what about diagnosis? So during the recent years, all societies that include liver societies around the globe, GI Society and endocrinology society, we agree that we need to step up identification from simple identification using FIB4 for identifying the patient at risk. So anyone more than FIB4 more than 1.3, that could be eligible for next step of evaluation. For the next step, it can be the more specific, liver-specific biomarker, or preferably VCTE, vibration control transient elastography. So if the VCTE greater than 8, that could be significant, and that should be referred to hepatologists for intervention. And with the more recent guideline, this is the guideline led by Sabir Younasi, recently published in Gastroenterology. So the same 2 steps, identification from FIB4 and then using VCTE as a second evaluation. Recently, there's been the study using more sophisticated identification using routine lab, 7 routine labs called SEP score from the Stanford, but need to be validated. So this SEP score can be clearly identify the patient at higher risk from the patient with low risk. The best thing so far is going to be the combination with whether VCTE or MRE, MR elastography, plus AST called mass and fast score. So you can see that the area under the curve is around 0.8 for mass and fast score. And this also can identify the patient after the treatment in terms of resolution. It seems that recent studies showing that both mass and fast can follow the patient, and mass may be better in terms of identifying the patient with mass resolution. And with that, with the next step, with a clinical study, FDA seemed to allow this surrogate endpoint instead of using the pathology in the previous study. So now, what about the MASH treatment? Then the key in the past, we just talk about lifestyle modification, weight reduction, but every time when the patient come back, they gain weight. So that is a problem. So for this year, we have so many medication for weight reduction, but again, we need to implement this medication together with lifestyle modification. And for the treatment, for those days, we got just only vitamin E and pioglitazone for probably the positive trial. But this year, we have more and more drugs in the market, and some of them already been approved for the treatment of metabolic-associated steatohepatitis. So now let's talk about weight reduction treatment. So this is the recent study on oral semaglutide for the doses of 25 milligrams daily, so that they titrate from 3 milligrams to a maximum of 25 milligrams daily, weekly, at daily at week 12. So you can see that at least 50% of the patients in the study can achieve more than 15% weight loss by the end of 64 weeks. So this is quite fantastic. And this is in the patient without diabetes. Now, the combo, like tirzepatide in comparison with semaglutide for the weight loss in the patient without diabetes. You can see that with semaglutide at a dosage of 10 or 15 milligram in comparison with semaglutide 1.7 to 2.4 milligram. You can see that the combo compound offer even more benefit in terms of weight reduction and change of weight circumference at the end of the study of week 72. Another study using once weekly medutide at 4 and 6 milligrams weekly in comparison with placebo. Again, the combo also have shown this the significant weight reduction at week 32 and week 48. So you can see that all of these compounds have shown significantly reductions of body weight and as well as weight circumference. Another study in also the using another class of medication, amylin analog, co-administered with semaglutide. You can see that the co-administered of cagrilintide together with semaglutide even offer more weight reduction in the patient without diabetes and also in the patient with diabetes. And also you can see improvement of hemoglobin A1C at least almost 2% at the end of the study. So these effective weight reduction medication will offer more benefit in terms of weight reduction, also adjust the metabolic dysfunction of the patient. Another study with this now long-acting combo, so once monthly. So it's not weekly anymore. This is monthly medication. You can see that the co-administrations of GLP-1 receptor antagonist with GIP. So once monthly, you can have the reductions of hemoglobin A1C up to 2% and also the weight reductions of almost you will see in diabetes cohort 17% weight reduction. So you got more glycemic control as well as weight reduction with all of these compounds. The last one got to be the oral GLP-1 receptor agonist. This got to be similar to oral semaglutide. So this new compound also offer weight reduction at least 11% at the end of the study. So you can see all of these are pivotal studies, landmark study published in New England Journal of Medicine. So, so this year, New England Journal of Medicine is busy publishing the studies on weight reduction and MASH. I'm going to show you in the next step. However, in terms of weight reduction with drug, so if it doesn't use with modification of lifestyle change, in terms of sustainability, it's not as good as bariatric surgery. So you need to add on lifestyle change and modify the diet in order to keep the patient losing their weight and sustain. Now, the most exciting part for hepatology is going to be the MASH treatments. So the potential treatment for MASH going to be the use of the drug that can modify the metabolic derangement. And also we got another compound that the thyroid hormone receptor, beta receptor agonist, that can also burn fat, and also reductions of LDL. And also we can have the medication that reductions of inflammatory or anti-fibrotic medication. Let's see what going to work. The first ever medication that has been proven for the treatment of MASH going to be resmetirom. This is the oral compound. The dosage from 80 and 100 milligram. You can see that at the end of the study, the improvement of NASH resolution up to almost 30%, and reduction of fibrosis at least one stage is about 26%. And this occur together with reductions of LDL as well. And this is the first ever drug approved for MASH treatment by US FDA as for March 2024. The second drug that has been approved for the treatment of MASH is semaglutide. So you can see with resmetirom 80 to 100 milligram, in terms of improvement of steatohepatitis, just about 30%. But with semaglutide, it is double, more than 60%. And in terms of fibrosis reduction from 26% to 36%, 10% more. So this is even better by using semaglutide 2.4 milligram weekly. Another study then combo, what about semaglutide, the GLP-1 receptor agonist with GIP compound. So this is the dosage from 5, 10 and 15 milligram. You will see it's going to be stepwise resolution in terms of the steatohepatitis improvement, but in terms of fibrosis improvement is quite similar between dosing of 5, 10, and 15 milligram. So this is just to compare at the end of the day. So the first two columns represent resmetirom, the violet represent the semaglutide, and the last three columns represent tirzepatide at a different dosage. You can see that in terms of improvement in steatohepatitis, so semaglutide and tirzepatide have shown similar improvement of steatohepatitis. But in terms of improvement of fibrosis, semaglutide improvement of fibrosis about 37%, and tirzepatide regarding the dose from 5 to 10 to 5 to 15 milligram, the improvement remained quite similar from 55 to 51%. Now, what about when we wait until the patient becomes cirrhotic? This is a study using semaglutide in the patient with compensated MASH cirrhosis. You see that there was some improvement in terms of fibrosis, but it did not reach statistically significant. So this is the negative result for semaglutide in cirrhotic patient. Again, using another mechanism in terms of anti-fibrotic, in using fibroblast growth factor 21 in compensated MASH cirrhosis. Again, it did not reach statistically significant as well. So just to conclude, ladies and gentlemen, so this year, 2025, is a golden year for MASH and MASLD. It is systemic disease with significant cardiovascular and metabolic consequences, and fibrosis stage, not steatosis, is the dictate of liver-related mortality. Risk stratification is the key. It must be simple for GP and for non-hepatologists, and the non-invasive is going to be the goal for us. FIB4 is identified as the best for GP, and then if significant, especially FIB4 greater than 1.3, then go for VCTE, and then if VCTE more than 8, refer to hepatologist. It is a new era for MASH pharmacotherapy. So resmetirom is the first treatment for MASH, but we we do not have resmetirom in I think in our region. I'm not sure whether in Singapore they have resmetirom, but at least in the rest of the ASEAN countries, we don't have that. But I think what's more exciting going to be semaglutide. That is very fantastic, and it is available for the treatment of diabetes already, and all of this incretin-based treatment, this is showing improvement of MASH and fibrosis. And management must be holistic. That's you need to focus on weight reduction, lifestyle modification, as well as aggressive controls of cardiovascular and also metabolic risk factors. With that, thank you for your attention.